Now, to put all of these presentations into perspective, I'm happy to introduce Dr. David Cescon from Princess Margaret Cancer Centre in Canada.
Good morning to everyone here in attendance personally and to all of those attending online. I'm very pleased to be here to discuss the results of these first three abstracts we've heard this morning. And I'd like to thank the organizers, the session chairs, for this opportunity, as well as the presenters who kindly shared their slides and answered my questions prior to today. These are my disclosures. I think we can all acknowledge that the last decade was a remarkable one for the development of CDK4/6 inhibitors in metastatic ER-positive breast cancer. From the initial demonstration that the in vitro sensitivity to palbociclib corresponds with a hormone receptor positive or luminal phenotype, to the pooled analysis by the FDA for 3 approved CDK4/6 inhibitors for progression-free survival, demonstrating an improvement whether combined with a aromatase inhibitor or with fulvestrant, we have seen a substantial impact on our current treatment today. And this is reflected, of course, in our most recent clinical practice guidelines, where the use of a CDK4/6 inhibitor in combination with endocrine treatment is recommended for most patients with metastatic ER-positive, HER2-negative disease. Over the last number of years, there's been great attempts to understand which of these patients benefit most from this type of therapy and how we might further optimize their use. Indeed, can we refine beyond this standard of care, either by refining the subset of patients who might benefit most, or perhaps by refining a specific CDK4/6 inhibitor that might be most relevant for a particular patient population. Finally, and as we heard in the last presentation, there's a great need to optimize the strategy for treatment of patients following the development of CDK4/6 inhibitor resistance, which we know inevitably occurs in the vast majority of patients with metastatic disease. To address those first 2 points, we have abstracts describing correlative or subgroup analyses from the Mona Lisa studies. And I'll begin here. I'm going to first discuss the second abstract that was presented, the subgroup analyses of the Mona Lisa 2 study of first-line ribociclib and letrozole. As we're all familiar, this trial of untreated patients with metastatic ER-positive, HER2-negative breast cancer, which added ribociclib to standard letrozole, has shown an improvement in progression-free and overall survival. The most recent updated overall survival data, as shown here, have shown a remarkable median survival of more than 5 years. In Dr. O'Shaughnessy's presentation, she described the overall survival subgroup analyses of patients with various clinical phenotypes. Shown here are 2 of those, which represent different ends of the clinical spectrum. At the top, bone-only metastatic disease, and on the bottom, patients with liver metastases at the time of enrollment. As was seen for all subgroups that were presented, an improvement in relative overall survival was consistently observed regardless of clinical features. However, as seen in these plots, and unsurprisingly, these clinical features retain prognostic significance, and patients with bone-only disease have a markedly increased overall survival compared to those with liver metastases at presentation. So from this presentation, we can now confirm with overall survival, as was shown for progression-free survival, that the relative ribociclib benefit is consistent, and that anatomic factors retain prognostic significance. Thus, this highlights the fact that the absolute overall survival benefit of ribociclib does vary by patient population. And indeed, it's perhaps those patients with the more indolent metastatic disease who gain the largest absolute benefit in overall survival. Perhaps surprisingly, when we sometimes consider who to treat or not treat with a CDK4/6 inhibitor in the first-line setting. Moving on to the biological correlates of CDK4/6 inhibitors in the Mona Lisa study. As was presented by Dr. Carey, a large correlative sample analysis was done from the pooled sample set, representing about half of the patients enrolled. In the sample set, roughly 70% were from primary tumors. The specific analysis focused on intrinsic subtypes using a derived PAM50 calculated from a larger nanostring gene panel. The intrinsic subtypes in breast cancer are a well-recognized biological classification, which have shown to be prognostic in both early and advanced breast cancer. As shown in the figure, the breakdown of intrinsic subtypes in this ER-positive, HER2-negative population is similar to as has been seen before, and consists mostly of luminal tumors, but also includes a subset of non-luminal cancers, mostly represented by the HER2-enriched group here, roughly 15% of the patients studied. As was shown in these analyses, the overall survival benefits of ribociclib added to endocrine therapy were consistent across the three main subtypes. The basal-like group, where no difference was observed, is very small, but as Dr. Carey emphasized, it's not surprising to see that a CDK4/6 inhibitor might not improve outcomes there. The understanding of intrinsic subtype in advanced ER-positive breast cancer is evolving, and there are several considerations that should be kept in mind. First, the analysis method used to calculate the intrinsic subtype may introduce some variability between samples or collections. And it's well recognized that switching in subtype occurs between primary and metastatic disease. Here's a figure from the recent Aurora analyses showing that some of the less aggressive intrinsic subtypes that are present in primary breast cancers evolve to perhaps more aggressive intrinsic subtypes when metastatic paired biopsies are obtained. Here we can see the luminal A evolving to luminal B, and enrichment in the HER2-enriched group in the metastatic biopsies. Again, we know that intrinsic subtypes correlate with some other clinical, anatomic, and from this meeting, genomic features. Here's data showing the intrinsic subtypes from the PALOMA-2 and PALOMA-3 studies, calculated in a slightly different way, where we can see that visceral disease tends to be comprised more of the more aggressive luminal B and HER2-enriched subtypes than perhaps bone-only disease. So the question is, and this was raised during the question period, what's the clinical utility of this information? Well, one hypothesis put forth and to be evaluated in the Harmonia study that was described was that perhaps ribociclib has an advantage in a particular intrinsic subtype. These data from the Paloma studies show that in Paloma-2, only a small absolute improvement in progression-free survival was observed in the HER2-enriched subtype. In Paloma-3 on the right, we do see, however, that an improvement in progression-free survival with a hazard ratio similar to the overall population was observed. Nevertheless, with this hypothesis, the Solte group is undertaking an ambitious and impressive clinical trial to evaluate the clinical utility of intrinsic subtype and to directly test head-to-head ribociclib versus palbociclib in this HER2-enriched group. It's important to emphasize that this effort will not only screen a large number of patients to identify those who have the HER2-enriched subtype, but will also do so in a consistent fashion from metastatic biopsy using a standard PAM50 classifier. This will obviously be of great interest in the ongoing development of this hypothesis, and we look forward to the other correlative insights that this study will yield. How about beyond CDK4/6 inhibitors? We have guidelines for endocrine treatment, as was described by Dr. Bardia, and those are largely based on clinical evidence that was obtained prior to the routine use of CDK4/6 inhibitors in the early line setting. We know that CDK4/6 inhibitor resistance occurs, and we know a variety of the biological processes that contribute to this. Many of these result in bypass of the G1 checkpoint, and this can be induced by a number of signaling pathways, or indeed by loss of RB itself. Maintenance of estrogen signaling is another important contributor to progression on endocrine and CDK4/6 inhibitor therapies. To build further on this paradigm of CDK4/6 inhibitor and endocrine therapy combinations in the early line setting, we need to either identify drugs that are effective in that second line setting, or perhaps to identify new combinations which may prolong the benefit and avoid the development of resistance in the first place. There's limited clinical trial evidence available thus far that has specifically evaluated a post-CDK4/6 inhibitor resistance population. These data from the Veronica trial, presented by Dr. Lindemann at ASCO this year, evaluated the addition of a targeted therapy, venetoclax, to standard fulvestrant in a second-line setting for patients who had prior CDK4/6 inhibitor. And while unfortunately the strategy did not succeed in this study, it's important to note the very short progression-free survival and poor performance of standard fulvestrant that was seen in this post-CDK4/6 inhibitor population. This brings us to EMERALD, the phase 3 clinical trial of elacestrant as presented by Dr. Bardia in patients with second or third line ER-positive, HER2-negative breast cancer. Oral SERDs are a new and emerging class of investigational agents which build upon the biology of fulvestrant, which we have used as an endocrine treatment for nearly 2 decades. SERDs result in the binding, immobilization, and degradation of the estrogen receptor and are known active agents. However, there's important limitations to fulvestrant in both its pharmacokinetics and potentially pharmacodynamics, and thus a great effort has been undertaken to develop new agents that are orally available and perhaps more biologically potent. More than 10 such agents have entered clinical development and have been and are being studied in the entire spectrum of ER-positive disease, from the neoadjuvant to advanced line settings. These are being studied in monotherapy, as in the EMERALD study, as well as in combinations, and phase 1 through 3 studies are underway. Thus far, most of our data comes from early phase studies which have shown activity of these oral SERDs in fulvestrant pretreated and in ESR1 mutant disease. However, in these phase 1 studies, a heterogeneous population and single-arm design precludes clear comparison of their role compared to standard agents. Some of these agents have demonstrated differential toxicity. As we will see in the EMERALD data, low-grade GI toxicities is a common toxicity across many agents. ESR1 mutations, which are a focus of the primary endpoint in the EMERALD study, are an important identified resistance mechanism to endocrine therapy, in particular in metastatic ER-positive breast cancer. These activating mutations in the estrogen receptor, which make it independent of the estrogen ligand, occur mostly following treatment with prior endocrine treatment, and mostly following treatment following prior aromatase inhibitor. The clinical features of patients with ctDNA detectable mutations in ESR1 have been characterized in a variety of settings, and features such as prior endocrine sensitivity, prior aromatase inhibitor, and the presence of bone metastases have been correlated with the detection of ESR1 mutations. In EMERALD, elacestrant was compared to a standard of care physician's choice of endocrine treatment consisting of one of 3 aromatase inhibitors or fulvestrant. The patient population had had significant prior endocrine therapy, with nearly 50% of enrolled patients having treatment in the metastatic setting, and 2/3 having prior adjuvant treatment. 145 out of the 477 patients had had prior fulvestrant. This was a pragmatic trial of patients who were being randomized and treated with endocrine monotherapy. The progression-free survival versus the standard of care for all patients in the intent to treat and the ESR1 populations, as Dr. Bardia described, are shown here. And both of these subgroups met their primary endpoint of improved progression-free survival. Comparing these side by side, we can see that the benefit of elacestrant versus the standard of care is larger in magnitude in those patients with ESR1 mutations, which might be expected where this is a recognized marker of prior endocrine therapy dependence. While we do not have data for those patients who have ESR1 wild-type disease, we can extrapolate from these 2 curves that the benefit in that group must be smaller and may be quite small. Overall, this new agent was generally well tolerated, with the principal toxicity based on treatment-related adverse events being nausea and vomiting. We will await, obviously, patient-reported outcomes to fully understand the impact of this on patient quality of life and on its potential for long-term treatment in other settings. Importantly, as has been emphasized, an early and rapid drop-off in the progression-free survival curves occurs at the first restaging, reflecting that many of these patients have endocrine-resistant disease. Focusing on those patients treated with fulvestrant, which may be a more direct comparison, given the prior AAI use in this population, we see again that elacestrant improves progression-free survival and does so by a greater magnitude in those patients with ESR1 mutations. Again, a substantial proportion of these patients do not benefit from either endocrine therapy and progress at that first restaging. So how do we move from EMERALD to everyday management of ER-positive disease? Again, important to emphasize that in the post-CDK4/6 inhibitor-resistant setting, a majority of patients do very poorly with endocrine monotherapy. And thus, identifying that group and identifying alternative strategies is critical. What are the features of both the enrolled population and of this rapidly progressive population in EMERALD? Important features include specifically their prior endocrine therapies, their prior response and duration of response to CDK4/6 inhibitor and endocrine therapy, and the genomic correlates of those clinical features. ESR1 clonality, as well as the presence of other alterations, may be associated either with the clinical outcomes or with the benefit from elacestrant. And the PIK3CA mutation status is, of course, relevant now in this population, where we have a targeted therapy for use in combination with fulvestrant for patients with PIK3CA mutations. What is a standard of practice and in trials? Is a physician's choice endocrine therapy appropriate? We might assume that patients who progress quickly could be salvaged with chemotherapy, although examining the overall survival curves, we see that there's roughly a 10% drop in overall survival at 3 to 4 months here in the standard of care arm, which is a concern and reflects that we need to choose patients for subsequent endocrine treatment carefully. So where do we go beyond EMERALD? I think it seems clear that oral SERDs are likely to impact our future practice. Here in EMERALD, we see clinical activity with safety and tolerability, although again, safety and tolerability must be interpreted in the context that it's used. The population and clinical positioning of these agents will be a focus of major investigation. And as was emphasized, oral SERD-based combinations are of substantial interest. To conclude, and reflecting back on the initial presentations in this session, I think we can all agree that ongoing clinical, correlative,